All right, it is 4 p.m. in California, so we'll go ahead and get started. I'd like to welcome everyone to our third PedsUroFLO lecture. Thank you all for joining us today, and I'm very happy to introduce one of my own mentors, Dr. Laurence Baskin, to talk about pediatric urology emergencies.
Thanks, Yi. It's great to have you moderating. Today we're going to talk about pediatric urologic emergencies. I hope everybody's doing well. This is what it's like in California when we're not having to shelter in, which is something that we're all kind of getting used to. It's almost a pleasure to have to go on emergency operation, so at least we get in the hospital. So today I'd like to do a case-based learning with lots of Zoom polling with our modern technology. And the goal here is to go over a number of varsity cases. These aren't like phimosis and paraphimosis. In other words, these are cases that I've seen over my career that Hillary and I have taken care of, that Yi and all the residents have become accustomed to being pimped and to learn and hopefully do what's not necessarily straightforward, the right thing for these patients. So the goal here is to guess the diagnosis, and then there needs to be a determination made. Is this actually a pediatric urologic emergency, or can this wait? So here's a practice case, just to give you an idea of what we're doing here. And Michelle put the poll up. And the idea here is I'm going to present, and then you're going to guess. So this is a septic 6-week-old who has the below anatomy, which is quite clear. An operation is done, and this is the operation. So your job is, once you sort this out, is to figure out exactly what the diagnosis is. And you have 3 choices here. And then to determine whether this is a pediatric urologic emergency. So this is our practice case. And I think you have about another few seconds here to get your answer in and submit. And then we can see how we did, which basically is what I would call excellent. So you can see the pus coming out. This indeed is an ectopic ureterosil in a septic child. And we all know that drainage is the best, whether it's just a puncture versus unroofing. I do think that this is emergency based on the fact that the child's septic. If the patient just had some debris, we're going to talk about that in a few of the cases. In other words, some shout and ultrasound, but was clinically well, then that's potentially semi-emergent. So I think everybody's good here. You definitely don't want to cause a vesicovaginal fistula, so you want to basically get your puncture in the right spot. And when toothpaste comes out, usually feel pretty good. This would not be an outpatient procedure. This child would be admitted, if they weren't already in the hospital, for IV antibiotics until they cool off. If the puncture is not successful in the sense of getting the pus out, then I would essentially unroof the ureterosil, like back in the day when you did bladder TUR, to basically get drainage and then move on at a later date for reconstruction. Okay, so we have an obstructed ureterosil, infected. Yes, this is a pediatric urologic emergency. All right, let's go on to the real cases. This is case number 1. This is a newborn with severe hypospadias. What is the diagnosis? And is this a pediatric urologic emergency? All right, a few more seconds to get your answer in, and then Michelle will bring up and see how we did. About a 50-50 split. So I think that it's difficult to do a physical examination by Zoom, and the only thing that we're having trouble with in our new normal is determining whether testes are in the right spot. But this patient, we have to be aware does not have hypospadias. And any patient with severe hypospadias, the most important thing is to palpate the gonads. If the gonads are not present, then we need to consider congenital adrenal hyperplasia like we have here. This is clearly life-threatening, secondary to salt losing. About half patients will have electrolyte abnormalities. If this patient presents at 6 months of age or a year of age, you know it's not salt-losing congenital adrenal hyperplasia, although if the gonads are not palpable, it still could be congenital adrenal hyperplasia. How do we make that diagnosis? Karyotype, pertinent labs, and we work with our endocrine team to perform an analysis to look for the most common cause, which is 21-hydroxylase deficiency, which would be a backup of 17-hydroxyprogesterone. The much rarer forms associated with hypertension would be 11-beta hydroxylase deficiency. And you can see on your steroid synthesis chart, which I know you've all memorized, the blockage in a particular enzyme will lead to a buildup of the precursor. Way down on the list in the smaller font is 3-beta HSD, a very rare form of CAH, actually described at UCSF, with a buildup of 70-hydroxyprogesterone. Making this diagnosis, I think, is not so straightforward in the sense that when you draw these enzymes right after birth or later on, they can vary at the time of day and also on the age of the patient. And so that's why we always work closely with our endocrine team, who's going to be prescribing the appropriate steroids as well as mineral corticoids to take care of the salt losing. All right, this is case number 2, okay? These are 2 newborns. Michelle, if we can have the poll. And I need a diagnosis and whether this is a pediatric urologic emergency. A bit of a hint, the sex is different in these patients and they're clinically well born at full term. A couple more seconds and then we'll see how we did. All right, pretty good. The diagnosis is cloacal exstrophy. And on the left of your screen is a male. Hopefully you can see my pointer. This is a hemiphallus. This is a hemiphallus, scrotum, scrotum, testicles either in the scrotum or intra-abdominal. In contrast, in the female, very difficult to see the hemicliteri because they're so small, but this is the vagina. Here's a bladder half, here's a bladder half, here's a hindgut protruding. For those who said omphalocele, you're correct, but I think the better diagnosis is cloacal exstrophy, which includes the omphalocele. Here's the omphalocele in the male, bladder half, bladder half. So the question is this a pediatric urologic emergency? And I think for the family it is, because certainly they're going to be distraught and kind of wonder why there's such a big abdominal hernia and that the anatomy is clearly not normal. But for us, I don't think it's really an emergency. The meconium will be able to come out through the hindgut. The urine will drain out through the ureteral orifices. Unlike bladder exstrophy, where you almost always have 2 normal kidneys without obstruction, cloacal exstrophy, as we know, is associated with a solitary kidney, with megaureters, often with Müllerian abnormalities, clearly imperforate anus, since there is no anus, and about 95 to 98% will have a tethered cord or some type of spinal abnormality. So our preference now is just to proceed with an elective workup. We've even sent these patients home, and then we brought them back at around 6 weeks or so, where we'll do osteotomies, colostomy, separation with our pediatric surgery colleagues. So cloacal exstrophy, back in the day when I started doing this, there were still some gender conversion from male to female. I think that's basically unheard of at this point. All right, case number 3. On the left is right side up, and on the right is upside down. I'm giving you a hint. There's one hole here, no visible anus, and no visible vagina. What's the diagnosis? And is this a pediatric urologic emergency? Also, do you need to check a karyotype? That would be kind of a third question. All right, a couple more seconds. And let's see how we did. Well, the patient definitely has imperforate anus. The patient's definitely a female. The patient has a cloacal anomaly. The patient has a normal cervix. So the answer is all the above. And is this a pediatric urologic emergency? Most of the time, this is, but some of the time it isn't. Why is it an emergency? Because if the meconium can't get out and backs up, then obviously you're going to have a problem here. So typically, depending on how severe this is, if it's a high confluence, then you absolutely need to have your pediatric surgery colleagues do a bowel diversion, and then as the child grows, then you can do the complex reconstruction. So that patient indeed had a colostomy at 3 to 4 months of age. We've been doing these 3D reconstructions, and I can take you through that. Where my cursor is, there's a little bead that we put on the baby's perineum, and then we basically put little stents, in this case ureteral catheters, into all the different anatomical structures you're looking for. For example, this is one in the bladder. This is the vagina, which is bilobed because this patient has uterus didelphys, so a cervix here and a cervix here. And then if you look carefully, this is the hindgut entering the back of the vagina, and you can see it here as well with a catheter in it. Once these 3 different catheters in, I inject them sequentially with a little bit of contrast, and they rotate through our 3D machine, and you get these really lovely images, which instead of having a big descriptor on what your examining anesthesia was, we can show these at our conference, remind ourselves immediately what we're dealing with, determine the length from here to here. 3 centimeters is kind of key. After that, it's kind of a tour de force. Before, much more straightforward, and really help with our planning and our outcome. So this is the same patient at the time of the pull through. And you can see in the right side up picture, we end up with a vagina and the anus in the correct spot. This is a cloacal anomaly, and the key is how or where the confluence is, as opposed to our urogenital sinus anomaly, which applies to our congenital adrenal hyperplasia and our urogenital sinus mobilization. So we've been really thrilled with these 3D reconstructions because we think they've helped for teaching, planning, and for ultimate surgery. All right, this is case number 4. And this is a baby who presents typically, at least at the time of the examination, a painless, hard unilateral testicle. Let's bring up our question. What's the diagnosis here? And is this a pediatric urologic emergency? The patient on the right presented quite a while ago. This is an old picture. I can tell that because of where the incision is going to be made. And this is the patient who presented. Actually, this picture obviously was taken in the office, this one in the operating room. All right, how did we do here? Most of you said torsion. A few said tumor. Tumor in the newborn can happen. I've seen it once, but I think that's pretty darn rare. Hard, painless mass is typically neonatal torsion, and the controversy continues because the chance of saving this testicle is close to 0, about 1%. So what are the facts with neonatal torsion? The facts are it's essentially a spectrum. In other words, this is a disease process that you're seeing at one point in time. And the patients I just showed, they were newborns. They had had testicular torsion maybe a week before, maybe a month before. And on the day they were born, you were basically seeing them with a dead, hard testicle. So I'd like to emphasize that neonatal torsion is probably painful at the time it happens. But once it's already occurred, then it's painless. If that baby were born and you palpated the testes and they were jumping out of the incubator or the crib, that could be acute neonatal torsion. That would be an indication for immediate surgery. And that would be your like 1 in 100 patient that you'd have a chance to save the testicle. If the baby's completely fine, there's no induration, there's no really pain when you palpate the testes, he's feeding and well, then that's most likely a dead testicle with a salvage rate that's close to 0. In those patients, the focus should be, and I love the way Dave Diamond describes this, the focus should be on the health of the contralateral testes. And in those babies, we typically offer orchidopexy, not acutely in the first 12 to 24 hours of life, but basically after about a week or at least after 48 hours when anesthesia is much safer because of the very, very rare incidence of asynchronous neonatal torsion. As I mentioned, tumors are rare. And finally, a tip that I learned from the Indiana group, Martin Kiefer in particular, is that I used to always explore these through the groin because I worried about a hydrocele, because newborns often have hydroceles, but it turns out if you explore them through the scrotum, even if there is a hydrocele, the patent process vaginalis still seals off, and their report says they've never been burned. And my experience is that you can just pex the normal side through the scrotum, and the side that has a torsion, typically take that out to confirm indeed that it's torsion. As noted, tumors, again, are super rare. All right, case number 5. This is the outcome of a neonatal circumcision. What is the diagnosis? And is this a pediatric urologic emergency? In other words, what happened here? All right, Michelle. All right, so again, a little bit controversial. This is actually, I kind of gave the answer away, sorry about that, a circumcision injury. So when we do a circumcision, which I don't in the neonatal period in general, the most important thing, as we all know, for like a Plastibell or a Gomco clamp, or when we do a circumcision freehand in the operating room when patients are older, is you need to take down the foreskin. You need to basically break up the adhesions of the inner prepuce from the glands and allow that foreskin to be retracted. So what happened here? In this case, the penile or shaft skin was pulled up into the Gomco device and was essentially excised. Well, if you have the skin, could you put it back on as a skin graft? And the answer is maybe. My experience, and this one is obviously a little more severe than others, is I have simply put Vaseline on the shaft and allowed secondary healing. And later on, you can then basically break up the adhesions during an operation and take your foreskin and use that to cover some of the shaft, although you're then going to have shiny shaft skin as opposed to the more penile skin. So is it an emergency or is it not an emergency? I guess if you have the skin, or you can consider like a skin graft, but remember, this baby is about 24 hours old or less than 48 hours old, and I think a big operation is just not the ideal scenario for a newborn. And just with Vaseline, it's amazing how you'll get the skin to just grow in with secondary epithelialization, and your outcome's not going to be all that bad. So circumcision issues. Bleeding, I think, is the most common, as we all know, and pressure, silver nitrate, and the occasional stitch. Obviously, bleeding after a circumcision is a big nuisance, so we take every precaution. There, again, basically technical issues. Infection, rare. Pain, rare. Skin loss, that definitely happens, and those are the ones that we often revise. This is from, as noted, a Gomco clamp injury where the penile shaft skin was pulled into the clamp. And again, this occurs because the physiologic adhesions were taken down. That's what I find the most common when you get these injuries that are a little more severe. Amputation, save the part on ice, and that is definitely an emergency, and that can be sewn on depending how much has been taken off. If it's super severe, we get our plastic surgeons and try to do the nerves and everything. If it's just a bit of the glands, we sew it on, and we've had pretty good success with that, fortunately rare. And chronic issues, as we all know, again, skin asymmetry, and then we'll occasionally see a fistula at the coronal margin from a crus injury, typically from a Gomco clamp, and that's different from a congenital hypospadias fistula or a megameatus. All right, case number 6. This is a newborn. I'm going to move my menu bar here, which is in the way. With severe respiratory distress. And as you can see, you've got a KUB, which you don't see a lot of bowel, and you've got an ultrasound, and I think the top left is the one that is most revealing, and we need a diagnosis here. And also, is this a pediatric urologic emergency? Michelle, how did we do? All right, most of us think this is a giant UPJ. I would agree with that. I would say if you just looked at the KUB, this certainly is consistent with posterior urethral valves. But the fact that on that upper left ultrasound, there was a massive amount of fluid, that's a little more consistent. Well, I know what it is because I took care of the patient. But what's a way to sort this out when you get an ultrasound that all you see is fluid and you're not sure whether this is ascites? We've been enamored, and I would be the first to agree that I've probably used this in situations where it didn't change management, but you certainly get pretty pictures. So what you're seeing here is basically a swaddle MRI. So we'll take these newborn babies or 1-month-old babies, and we can pop them into the MRI machine without an IV, without any sedation, just after they've breastfed, and they can do about a couple 3 or 4 minute sequences and get really spectacular imaging. So in this case, you can see the massive left UPJ. In the bottom left, you can see the normal kidney, as well here is a normal right kidney. And normally with giant hydronephrosis or beach ball hydronephrosis, you don't typically get respiratory issues, but this child ended up having to be put on a ventilator from compression of the diaphragm. So in that situation, options are nephrostomy tube, which everybody, all of my residents know I can't stand using those except in very unusual circumstances. So I've been a big believer in kind of temporary diversion because I think it sets you up for success, as well as makes your subsequent surgery much more straightforward. So in this case, basically make an inch or 2 incision on the left side. We drain the kidney. This is that same patient now who's over a year of age, or approximately. You can see the diaper that's used for drainage. You can see the MAG3 study shows an absolutely spectacular kidney. And then through that same incision, in this case, it would be for us a rare open pyeloplasty to fix the UPJ and correct the healthy kidney. I think a nephrostomy tube will decompress the system, but then what do you do? Because you're not going to fix it, a few weeks afterwards. This way it takes all the pressure off the patient, the family, as well as yourself, and allows for excellent long-term success. All right, here's a 6-week-old with sepsis. Okay, so the history is important. And you get an ultrasound, and the ultrasound shows something very specific here. And your choices are debris, reflux, primary dilated megaureter, or renal failure. I'm looking for the best diagnosis here. And is this a pediatric urology emergency? So the hint would be the bottom right picture. And I'm going to tell you that this is the bladder, which is normal, and this is the ureter, where there's something in there that's not normal. So let's get our answers in and see how we did. Okay, so everybody's getting this wrong. except for me, because I thought it was debris, and I even voted on this one. But we did get it right that this is a pediatric urologic emergency. So why is this not a primary dilated megaureter? Let me go back to the ultrasound. First of all, we don't typically use the term primary dilated megaureter in duplex systems. And I think this is a pretty good representation of a lower pole here with upper pole height and nephrosis. Here's your lower pole here. Here's your upper pole height and nephrosis. And this is basically the big fat ureter. And this is supposed to signify debris in the ureter. And I told you the kid was septic. So you're thinking infection. This actually was done well after I initially treated the patient. And then you can see the left kidney's fine, the right kidney, there is function in the upper pole. Why do I want to know that? Because if there isn't function, then my approach would be a laparoscopic upper pole partial nephrourectomy, which is a super fun operation, definitive, and gets the job done. But this is a patient who was sick. Upper pole ectopic ureter going underneath the lower pole, so that's a good illustration of the Weigart-Meyer law of the crossing ureter in a duplex system. Here you can see the normal lower pole ureter, that upper pole ureter coming up. And I'm also going to basically say that in a kid who's super sick, my choice in the little baby, in other words, under like a year of age or so, a year or younger, would again be temporary cutaneous diversion. Now, I don't do lots of pilostomies and urostomies, but I would say, 3 or 4 times a year, I think this is a fantastic way to deal with these complex patients. Why do I do this? 1, it allowed the septic urine to drain out easily. 2, it avoided the nephrostomy tube, and I told you the reasons I don't like that. 3, it allows the ureter to completely decompress and become nice and delicate. And this turns, again, this patient who I think is basically an emergency or definitely semi-urgent into a cured baby. And then 6 months, 9 months, or a year later when everything's fine, I would go back and do either a UU or I would take the upper pole ureter and reimplant it to the bladder. Again, based on that MAG3 study, because there's good function and the long-term results basically are excellent and you get closure. All right, case number 8. Is this a pediatric urologic emergency? This is an 18-month-old with left inguinal swelling, pain, and vomiting. And you can see in the photograph that the right testicle is normal. The left side, you don't know exactly what's going on down here, but this doesn't look correct. So what is a concern with this diagnosis? Okay, so this is worded a little bit differently. And is this a pediatric urologic emergency? And take a look at the history. It certainly looks like it's acute to me. Michelle, how do we do? Here we go. Exactly. So what I'm worried about here is a hernia. And if you have a hernia and the testes, we know undescended testes have an increased incidence of hernia. So you've got some bowel in here, and what it can do is basically cause ischemia of the spermatic cord, and you can lose the testicle. So this is definitely an emergency. You should be operated right away, and everybody looks like they're pretty much on top of that. Hydrocele, hernia, the bowel gets in, causes ischemia to the spermatic cord, and with a kid with symptoms, right to the operating room. All right, this is kind of quasi, not really related, but it does involve the groin. This is an asymptomatic baby boy with abdominal scrotal swelling. And the marks that I made on this child are significant. There's one here and one here. This baby's just well in the clinic, kind of hanging out. What's your diagnosis? And is this a pediatric urologic emergency? Abdominal scrotal hydroceles, I agree with the answer, and this is not an emergency, at least from the best I can tell. We've kind of seen a bunch of these, done extensive review of the literature, and to me, this is like the Southwest commercial. If you start operating on this, you're going to want to get away because these are extremely tedious and difficult to fix. And my experience is that they go away just with observation and they're not at risk for hernia. So abdominal scrotal hydrocele is kind of a varsity hydrocele story. If you put one on your list, be prepared to be there for 2 to 3 hours as opposed to 15 minutes. Definitely complex. Okay, this is a teenager and you find some squishy stuff in the scrotum on your examination. And then he goes to the operating room. What is the least likely thing you would see in a hernia? I'm going to give you the answer. This is omentum and his hernia. But what's the least likely thing you would see? Okay. I would say most of you didn't read the question, but you definitely got that it was omentum. And the correct answer would be ovary, which 70% of you guys nailed. Ovaries stay in the abdomen except 0.001% of the time. Ovaries do not descend. In patients with disorders of sex development, if you feel a gonad, the chance of it being an ovary is close to 0. Not 0, but close to 0. Certainly bowel comes out of hernias, appendix, testes, VP shunts, bladder would also be probably pretty rare with ovary, but ovaries really don't come out of hernias. This patient presented in the office with a squishy scrotum. Ultrasound didn't show fluid, and I was pretty sure he had omentum, and it was semi-urgent because he was clinically well, so in the next day or two, we got him in and got the omentum back where it belonged. All right, this is a 3-year-old with testicular pain. He's well, other than the pain, and most patients like this don't get an operation. What's the diagnosis, and is this a pediatric urologic emergency? I think this case is kind of just for completeness. I think everybody's pretty familiar with this. Let's see how we did in our poll. Correct, torsion of the appendix testes. Could be torsion of the appendix epididymis, but in this case, it's the appendix testes because it looks like it's coming off the testes more, and the appendix of the testes is a lot more common than the appendix of the epididymis. I agree that it's not typically a urologic emergency. Torsion of the appendix testes occurs typically between around 3 to 6, maybe 2 to 8. It's a Müllerian remnant. It's what would have been the uterus that melts away with MIS. Pain is typically slight. In fact, I think most patients never come to our attention because they might be a little bit irritated, then it just goes away. The ones that can be tricky are if there is a large reactive hydrocele, so it's hard to palpate. If you can make the diagnosis, non-operative approach is, I think, totally fine. Patients with lighter skin, you can often see a blue dot, and imaging is appropriate to confirm a non-operative diagnosis. We've had some cases recently where it's so swollen and tender, patient has an increased BMI that we just can't figure it out. And one in particular I'm thinking of, which our residents will know, we just operated and found a hugely enlarged appendix testes that are torsed. And what's nice for those, if you operate and get rid of it, yes, you're doing the operation, but basically the child is going to be fine by the next day. So I think you can decrease morbidity in the rare case where this is a big nuisance for the patient. So I think it's an emergency to make the right diagnosis, but it's not an emergency in respect to typically needing surgery. I'd contrast that to a 14-year-old acute onset testicular pain, nausea, and vomiting. He has a high reading testes on exam. One of our key kind of messages to the ER folks is that if a young male has abdominal pain, definitely need to examine their testes because that can certainly have referred pain. Also, teenagers are typically always hungry, and when they have testicular torsion, they're not. And so this is pretty straightforward in respect to that you would bring this patient right to the operating room. And the goal is to get him before this occurs. My theory is that wimpy kids do better with a diagnosis of torsion because they come to the hospital quicker, whereas the ones who are tough it out, if they come 2 or 3 days later, that's obviously suboptimal. The contralateral side is what the focus should be on here. Definitely, I think, more critical. Just as for clarification, the patients who have neonatal torsion after 6 months of age, for sure, I don't think there's any point in doing a contralateral orchidopexy. We don't recommend or do, and there's really no data to do a contralateral orchidopexy in a patient who has an undescended testes on the opposite side, that it's going to help at all. But for neonatal torsion, for at least the first 3 months, there is a very slight chance of twisting, so that's why that's not unreasonable. For teenage torsion like this, key always do a contralateral orchidopexy. So we kind of went over this. High riding testes, the associated nausea and vomiting. You have about 8 hours. If you try to detorse, which our radiologists as well as ourselves try to do, some pain medication on board is helpful. And if you're standing at the base of the bed, opening the book is key. And we have not found fasciotomies, which have been in the literature lately, to be helpful. We think once a testicle's dead, it's pretty much dead. And we would remove a testicle that appears non-viable after opening up the tunica and seeing if it pinks up and the germ cells are black. Then we just don't think we're going to get much out of that testicle long term. Okay, this is a 5-part, actually 6-part question. Case number 13. These are urethral introital masses in a neonate, an older girl, okay? So what diagnosis is not seen in these girls? And are they a pediatric urologic emergency? And forget E, because E's an older child. That's not a pediatric urologic emergency, but it is one of the diagnoses. So this is a multiple parter, so you're gonna have to work quickly because I think Michelle's only giving you 30 seconds. And your options are what's not there. All right, we're definitely across the board here. And let's go over this, try to clear it up. All right, so on the left side, I agree, this isn't the clearest picture I've ever taken in the world, but this is a prolapsing ureterosil. It's thin-walled. How would you confirm that? Well, do an ultrasound. You're gonna find a duplex system, 80% of the time with upper pole hydroureteronephrosis. And this is so ectopic, it's coming out through the orifice, and you'll see this twice in your life like I have. All right, this is in the midline. In contrast to this, which is on one side, this is an imperforate hymen. So this is blood from maternal estrogen. This can be taken care of usually at the bedside, or it may go away on its own. This one happens to be a little more pronounced. The Skene's gland can also be taken care of at the bedside, and it will go away on its own. I've only seen this once in my life. It didn't look like this. It wasn't quite as protruding, but rhabdomyosarcoma, which you've read in the textbook, it can happen. And then in older children, urethral prolapse. The correct answer was ovirus syndrome, which does not present with protruding stuff coming out of the introitus, but it's such a favorite diagnosis of mine. I need to figure out how to talk about this in pediatric urologic emergencies, which it kind of is, because the classic presentation of ovirus syndrome, which I think, if you're not familiar with, is obstructed hemivagina ipsilateral renal ligenesis. And this is a disease or a diagnosis that you need to think about. It's not so obvious. So the classic presentation, although we've now made a couple diagnoses on prenatal ultrasound and in babies, but typically these are teenagers that present with cyclic abdominal pain after puberty. So that would be classically imperforate hymen. Sorry if I said imperforate anus before, imperforate hymen. And those patients, you would simply open up the hymen under anesthesia and all the menstrual fluid would come out and the problem would be cured. Another diagnosis might be vaginal atresia, where there's no connection, but with a normal uterus. That can certainly occur. But a much more common diagnosis, I think, because we see this more commonly a few times a year, is a patient who has solitary kidney, uterus didelphys, as you can see here, and then on the side that's missing the kidney, they have an obstructed hemivagina. It turns out that these patients actually aren't missing a kidney. They have a tiny ectopic nubbin of the kidney that's basically usually at the common iliacs with an ectopic ureter inserting to the vagina. So there's a few drops of urine that fills this up. And this hemivagina, basically, as a child menstruates, fills up with blood that can't get out. Here's some imaging to kind of show what's going on. Normal cervix, this is the fistula and the obstructed hemivagina. Contrast in the normal vagina and fallopian tube. Contrast in the obstructed hemivagina with the septum here, and then the refluxing ureter. We typically laparoscopically take the nubbin of kidney out. You have to because it's a few glomeruli. And then we also take out the septum in the vagina to allow good drainage. And Bruce Schlomer at Dallas, Bruce wrote a nice paper on this where we have this beautiful schematic that Bruce drew. And this is a little bit bigger than what we actually see, but a little nubbin of cystic kidney, sometimes it can be 2 ureters. This will insert topically. So we take the septum out to allow drainage of the obstructed hemivagina, and the solitary kidney, of course, on the right side is left alone. All right, case number 14. A newborn with prenatal hydronephrosis, routine, seen at 3 months follow-up, clinically totally well. This is what I'm interested in. What's the diagnosis? Again, we're on a theme here. This is a clinically well baby, and is this a pediatric urologic emergency? Let's see how we did. Okay, better. This was debris in the kidney, and in a well baby, or we think it's debris, and that's our theme here today is it debris or isn't it debris? And I think how the patient's doing is critical. When we look at our ultrasound colleagues' research on this, they seem to be about 50% accurate. So if the patient's not sick, then I don't get as concerned. In this baby who was well and on prophylaxis, I did a cath urine, which came back E. coli, treated it as an outpatient, and the debris went away and the kid did well. So I think with the prophylaxis, got a subclinical infection, so was hanging in there fine clinically, but if we hadn't done something, probably would have got super sick. So I'm going to call this semi-urgent, and just bringing up the concept of this quote unquote debris on ultrasound and what we do with that. And I think we're learning a lot, and it's my impression that about 50% of the time this is clinically can be a real issue. Okay, 15, this is a patient with trauma, and you can see there's a problem here, and there's actually an exit wound here. What's the diagnosis? You have 4 choices, and is this a pediatric urologic emergency? How we do, Michelle? We're pretty much on course here. So we got a CT scan because I wasn't sure where that stick was going. And you can see it kind of slid right along, but luckily superficial. We were worried about bladder injury, bowel injury. He was clinically stable, so we didn't think he had pierced a major artery. We then brought him to the operating room, and I think we can just pull it out in the ER. We pulled the stick out. I did leave that suture there so I could irrigate, and left kind of a drain on both sides to pull out because I wasn't sure what type of mites or what grows on sticks in California, but it has to be something not particularly good. But I would say this was one super unlucky kid who wasn't a great tree climber, but super lucky in that when this did pierce through him, it didn't really get any vital structures. All right, we've got 3 more cases. Number 16 is a newborn with a traumatic vaginal delivery. And this is what his exam of his external genitalia looks like. I'm also going to show you what is kind of the key image here is ultrasound of his right kidney. And there's a little bit of hydronephrosis, which is not particularly significant, but something else going on, which is consistent with this finding in the newborn exam, as well as the traumatic vaginal delivery. So what's your diagnosis, and is this a pediatric urologic emergency? Adrenal hemorrhage, good job. And is this an emergency? Well, it can be an emergency because there can be a fair amount of blood loss, but typically it just needs to be monitored. This scrotal swelling, you can get confused. Is this neonatal torsion? Is this swelling just from the trauma, which we think it is, but this can actually be blood that's tracking all the way down from the adrenal hemorrhage. So if you see something like this, I think a kidney ultrasound is indicated to assess the adrenal glands, as well as a hematocrit, as well as definitely watching this baby for other types of internal bleeding. All right, case number 17, intermittent blockage of the urinary stream. And you do endoscopy, and this is what you find. So what is your diagnosis? And is this a pediatric urologic emergency? All right, interesting. So this is a benign fibroepithelial polyp from the prostatic urethra, which is not a Mullerian structure because it's coming from the prostate, so it would be Wolffian. And it's semi-urgent unless you have urinary retention, which is pretty unusual. Typically you have, I guess, what we call stranguria, or intermittent, basically really pain with urination. If these grow big enough, they can be pretty easily seen on ultrasound, because and the idea here is that it's growing from the prostate back into the bladder, and you're essentially getting a ball valve. You can take care of it with our pediatric instruments, but using our loop like we'd be dealing with bladder cancer. And the idea is you don't want to get the Vera Montana off, you just want to get the benign polyp off. And so the good news now is it's resected, but then I got to figure out how to get it out of the bladder. And if they're so big, what I would do is just perk in with a 5mm laparoscopic port and pull it out that way. This one was small enough that I think I was able to cut up in the bladder and get it out. So benign fibroepithelial polyp from the prostatic urethra, semi-urgent in that these kids can present with reasonably aggressive symptoms. Okay, in our final case, urinary retention after straddling a fence hard. And you can see the physical exam here. What's your diagnosis, and is this a pediatric urologic emergency? How we do, Michelle? Posterior urethral disruption, definitely an emergency. And I have the luxury of having Ben Breyer and Lindsay Hansen to help me. And when I talked to Ben, he basically said, you have 20 minutes in the operating room to try to align this, otherwise you're going to abort. So this was my attempt. It all looks good until I flipped the fluoro machine and still found out at 90 degrees that I was like 5 centimeters away. So suprapubic tube was placed, and primary urethroplasty was performed 5 months later. Traumatic posterior urethral disruptions, I think that if there's no associated severe injuries, we do try primary alignment. Oftentimes, there's a cracked pelvis, hematomas, bleeding, and at that time, if that's the scenario and we can't take any time in the OR, then we just deal with a suprapubic tube. So we covered a fair amount of pediatric urologic emergencies. There's many, many more. Renal vein thrombosis, malignancy, AV fistula, trauma as a whole, another lecture, and then how we deal with bleeding after surgery, and now how we deal with bleeding during robotic surgery, etc. But these, I think, are kind of good varsity cases to think about. They allow us to kind of hone in on, we want to deal with emergency, but we want to set ourselves up for kind of long-term success that would relate to, temporary diversion, etc. I would like to shout out to our UCSF residents for working hard, and all you guys, fellows around the country and around the world who are also working hard in this particularly stressful time. Hillary would like, or actually I have no disclosures, I was supposed to say that earlier on, and we'd like to get some feedback, so you guys know what to do with this, and I think hashtag #PedsUroFLO, you can visit the website, and thanks for your attention.
Great, thanks for a great talk, Dr. Baskin. We have a few minutes and some really good questions, so we'll get right into it. One question from Mexico: do you always perform a testicular torsion through the scrotum? Because it could be a testicular tumor that presents as an acute scrotum. So what are your thoughts on that?
Yeah, I think that's a great question. I mean, eventually there's going to be a tumor that could have torsed or whatever. I haven't seen that yet. So the history of patients who come in with testicular tumors, let's separate out and talk about the teenage patients, because they're going to have, torsion, the teenage torsion. Tumor presents differently. Tumor presents as a hard mass. They're not nauseous. It's typically, more elective than comes with torsion. So I haven't been burned, and I always perform through the scrotum. And as our residents know, and Yi specifically, I'll do like 2 transverse incisions. I'm not a big fan of going vertically, because that's where the nerves come into the scrotum, and not that the scrotum needs to be, your most sensitive spot in your body, but if you're going to cut the nerves, it doesn't make any sense to me. So transverse incisions. And for neonatal torsion, the same thing, haven't been burned with a tumor. I think tumors present differently.
Great. A question about giant UPJ. When you do that surgery, do you end up reducing the size of the pelvis?
Yeah. So this kind of beach ball, massive UPJs, you can see the case I presented, I did a pilostomy, and that was basically temporizing. It reduced the size of a pelvis on its own. The MAG3 amazingly showed a super kidney, and I think it was about 9 months later when I did the primary pyeloplasty, your pelvis was gone. So the answer is that I will reduce the size of the pelvis, so I'm doing it primarily, but I think the most important fundamental issue with all pyeloplasties is to get a dependent, about 1 centimeter away from the lower pole, anastomosis, and the reducing part is kind of secondary.
Great. Kind of a follow-up to that. For this question says, for duplex megaureter, which level of diversion do you do? Okay, so I'm going to interpret that as I've hammered into all our residents, so I'm going to pick on Yi. He's asking the questions, but Yi knows that when you have a duplex system with upper pole hydroureter nephrosis, okay, duplex system, you're not going to have an upper pole UPJ, because that doesn't exist in the history of the world, except for one case I can show you, but that's another story. If you have a duplex system with lower pole hydronephrosis, that's a lower pole UPJ. So you're talking about upper pole hydroureter nephrosis, and so your differential is either ectopic ureter or ureterocele. For ureterocele, I tend to puncture, decompress, and then reconstruct at a year of age if there's reflux, which there almost always is. For ectopic ureters, if the kid gets septic, or if it's so big that primary reconstruction may be difficult, and that's rare, what I typically do, which I learned from Dr. Tanago, my mentor, is I'll take that upper pole ureter, and I don't care how big it is, and I'll reimplant it into a lower pole ureter.
It's called a UU. We're all familiar with that. The teaching point there is that if your ureter is normal, you can take that abnormal ureter and put it into the normal ureter, and it's going to work perfectly and not have any issues. So for an ectopic ureter with good function, my approach is a UU. For an ectopic ureter with minimal function, my approach is a laparoscopic partial nephroureterectomy. For urethrosil with no function, my approach is laparoscopic nephroureterectomy. For urethrosil with upper pole function, my approach is puncture as a baby and then go back at a year of age and reimplant the ureter and usually kind of excise the urethrosil. I hope that's helpful. These are complex questions. That's a complex question you asked. That's a super varsity question with lots of variables.
Great. A follow-up question to that: at what age do you tend to operate for UPG obstructions that are diagnosed antenatally? How long do you wait?
Yeah, that's a great question. So let's just call them unilateral because 90% are going to be unilateral. So my algorithm is to confirm the diagnosis postnatally with an ultrasound at around 2 to 4 weeks of age. I must admit I usually do a VCUG, but all the literature says that's a complete waste of time, so I've even backed off on that a bit. If it's a classic UPJ and ultrasound, then I do a MAG3 study at around 2 months to 2.5 months to 3 months of age, and then I do one more ultrasound like a month after that, just to give it a chance to get better. If the MAG3, showed indeed it was a UPJ and it looks like a UPJ, then I typically fix them robotically at around 4 to 5 months of age to 6 months of age.
Great. There's a question about your favorite case. So for a virus syndrome, have you ever considered doing a DMSA to look for renal tissue on that side?
The answer is we have done DMSAs. And, we've done MRIs. On the DMSA, there's like 25 glomeruli there, or maybe 250 as opposed to the normal 1 million. So DMSA has not shown any viable tissue. Adam Hittleman at Yale, hats off because I know they're going through some tough times there. Adam is the one who really helped me with this, as well as Bruce and Jason Wilson. We would basically study the MRIs looking for this nubbin of tissue, which we knew had to be there. And then we would go back to our radiology colleagues and go, is this it? Is this it? And they go, oh, it could be it. But I can tell you that that little nubbin of tissue typically is at the common iliac, and it's small. It's nice when it's kind of cystic or, there's some multicystic aspect to it because it's easier to see. And we have one patient I did recently, which I actually couldn't find it. I'm going to have to go back and look again. I just took care of the septum problem because the kid had pus in there. But that nubbin of kidney could be hard to find. Unfortunately, it doesn't light up on DMSA because there's not enough functional kidney tissue, and MR is kind of your best bet.
Great. A question about posterior urethral valves. What do you prefer to do with a catheter versus cystotomy, and how do you make that decision?
Catheter versus
a cystostomy.
Okay. Yeah. So valves, I have this bias that if you leave a catheter in for a week or two, the valve's going to melt away, but I've never been bold enough to not go in endoscopically and, excise it. That's kind of the standard of care. So treatment of valves, I guess some of the tips and tricks, if it's a premature baby who's intubated, vesicostomy and bailout, that's not that unusual, but fortunately reasonably rare. If it's postnatal healthy kid, then primary ablation. I think we're all familiar, or just emphasizing Patty Dewan's work from Australia. It's not really a valve, it's a membrane. So a better term is complete obstructive posterior urethral membrane, or COPM. We typically see these patients because we have a prenatal diagnosis. We put a catheter in, or the radiologist for the catheter, and then we do a VCUG. We've popped open the valve with that catheter. And so we've changed it from a complete obstructive or almost complete obstructive posterior urethral membrane to essentially kind of the classic valve that we see when we do endoscopy. Remember, it's only a few cell layers thick, so the feeding tube may just melt it away, but I haven't been bold enough not to go back and just look in endoscopically at, day 2, week of life, whenever, and resect all possible tissue.
Great. We still have a few good questions. We're running a little short on time. So the questions that we don't get to, we'll send to Dr. Baskin and we'll post on the website. There's a quick question we can maybe answer. What machine do you use for all of your wonderful images that you're showing?
What machine? I use Dr. Yi Lee for all my wonderful images. He helps. I don't know. We have great radiology colleagues and we do conferences, all the time with them. So, those guys are state of the art. So shout out to our radiology colleagues.
Great. I think that's all the time we have for now. We're on the hour, so I want to be respectful of everyone's time. Thank you so much, Dr. Baskin, and thanks everyone for joining in. And we will see you next Tuesday for our next lecture.
Thanks, Yi. Thanks, everyone. Be safe, you guys.